It's a huge problem.
This is what the fentanyl threat looks like.
It's at least 50 times more potent than heroin.
Fentanyl and other high-potency synthetic opioids.
These drugs are so potent, so terribly potent, that the person has no idea until they die.
Part of being a physician is seeing people take their last breath, seeing people in the worst possible shape. How do you handle that emotionally? Do you feel you're desensitized? Dr. Stanley Atkins, you've been practicing medicine for 55 years. You're one of the top AMEs in the United States. You've been an AME for 23 years, issuing pilot medical certificates. You served in the Air Force as an internist, and you're an ICU doctor. University of Indianapolis undergrad, Indiana University for Medical School, National Vice President for the American Heart Association, and you're a coroner for 8 years. Thanks for coming all the way down from Indianapolis. Welcome to the show. Pleasure to have you.
Thank you very much. It's a pleasure to be here, an honor. Thank you.
You're an aviation medical examiner. You do all the tough cases, all the special issuances, all the complicated cases. How did this all start?
Actually, it started because the Grissom Air Force Base had B-58s. B-58s. And if you look on a sectional map, you'll find that there's a MOA in northern Indiana called the 12-mile MOA. 12 miles where I was raised. I was raised 1 mile from 12 mile, but a B-58 really at speed, it doesn't matter. And we didn't know why there were so many booms in our area. And this is because back in the day, there was really no regulation. So when the boys in the B-58s wanted to go play, they'd find an MOA, which was over my house, and they'd go play. So it was quite an adventure.
I like booms.
Booms are good. The more immediate thing at that time was the fact that my mail carrier, who actually happened to be one of my relatives, was in the Second World War in the South Pacific. And we have pictures of a couple of planes that he got shot down in, and he survived very nicely. Planes didn't. And so when he became a civilian, he had a early model Piper that he flew out of the back of his house. And I was therefore introduced to an airplane at a very early age. There was a gentleman down the road from him a little bit who also flew. He was an A&P, or what was the same at that time, but he also had narcolepsy. So he would go to sleep flying an airplane, which is, of course, problematic. So he always had to have somebody go with him. Fortunately, I was not the one. I'm not sure that would have been very helpful for him. The Grissom Air Force Base was about 40 miles to the southeast of the farm. I was raised on a farm. And we got to know the place early on because they had a swimming pool. So the church youth groups would go down there to swim. And of course, it was not a heated pool, so sometimes the swims were somewhat brief, but it was we got introduced to the air base. We didn't get to meet any people because they didn't talk to children at that point. It was fun.
And where'd you go to medical school?
I went to medical school at the University of Indianapolis, or University of Indiana. I was told before medical school in college that if I went to medical school after 3 years, it would save a lot of money. I didn't know any better, so I did and applied, and I had one interview, and I had no idea what that meant. Was that good or bad? So I went back to college, and about 3 or 4 weeks later, I got this envelope that said, "You've been admitted to medical school." Well, I was raised on a farm, so Dad was a farmer, Mom was a teacher. Called up my dad and said, "Hey, Dad, I'm going to be a doctor." He said, "That's good." That was all the emotion there was. That's fine. Glad you made a decision, son. And then medical school was basically fatiguing. That's kind of 4 years of not much sleep. Finished that, and we went through the basic sciences and the clinicals and so forth. along with everybody else. And then I did my internship and residency at the Methodist Hospital in Indianapolis. It was at that time the third largest hospital in the United States. And we saw everything. Then went into internal medicine and residency in internal medicine. I had an opportunity to go into cardiology and radiology, and I wasn't smart enough to do that. So I ended up being an internist. Air Force was fun. I was supposed to go to a teaching billet in Washington, D.C., and 1 week before I was to ship out, they decided they needed an intensive care doctor in northern Maine. It was a B-52 base called Loring Air Force Base. So I went up there. We had 15,000 troops. We had a hospital intensive care unit. And I was an internist, not a flight surgeon. But all of my friends, well, some of my friends, were flight surgeons. We were housed in what was formerly the World War II barracks. They'd been reconditioned so families could live in them. And our neighbors were the B-52 KC-135 pilots. So we would tell them pilot jokes and they would tell us doctor jokes. And it was kind of fun. Went through that and had some experiences at the hospital in the Air Force that were significant. Perhaps the first one was I was in charge of the hospital at one point, and I was walking down toward the emergency room, and there was a military policeman who said, "Sir, you can't go down here." "Okay, why not?" He said, "Well, they're bringing in a body." Okay. Should I go down there? I said, "No, we're waiting for the pathologist to come in from Boston." So they got a KC-135 to fly him up to do the autopsy on this body. So he comes in and tries to be pleasant. He's really not pleasant because he had to come up from Boston. It wasn't much fun, but he was a professional. So he went in and did the autopsy after they brought the body in. They'd found the body in a trash dump, by the way, which was significant because when he came back out, I asked him what he'd found, and he said, "That is the nicest black bear I've ever seen." The black bear had been scavenging for food in the trash dump and either got shot or died there. And the police thought it had to be a body. It kind of looked like a body. So that was interesting. We had a couple of flight surgeons, good people, but the flight surgeons in that day really didn't have a huge amount of experience, that we were all young, and didn't have a whole bunch of aeromedical training because it kind of didn't exist. So we had a B-52 crew coming back from Lincoln Heath, England, and on the way back down from altitude, the navigator could not clear his ears, and he was suffering a lot. So they went back up and called to speak to the flight surgeon, who got on the phone, and they said, "What do we do with this fella?" And they'd already gone through, it turns out, the correct procedures, tried to clear the eustachian tubes, but it didn't work. So our flight surgeon, being young and not having a whole bunch of better ideas, said, "I want you to put your mouth over his and blow real hard."
How'd that work out?
Well, the radio went blank, and after 3 or 4 minutes, Matt came back on and said, "Thank you, sir. He's feeling much better." After the Air Force, I went down to Columbus, Indiana, which is about 40, 50 miles south of Indianapolis, Indiana. And at that time, Columbus was a very active town, still is actually, because it's the headquarters of Cummins Engine Company and a couple of other international companies. So we had a varied group of people to take care of. The hospital was about 350 beds. And at that time, the hospital had about 150 physicians on the staff. So it was pretty active. It was highly ranked. So that's when I really got involved in what I'm interested in now, which is cardiovascular disease. There are only 2 of us who took care of heart attacks for 11 counties. And since we were partners, one of us was on every other night. So we got to see a whole bunch of heart disease. We would usually see 3 or maybe 4 heart attacks per cycle each. And we would shock these people and intubate them, try and get them up to the city for surgery because we didn't have any local surgery and angioplasties did not exist at that time. So we had a big block Chevy and an ambulance, and we had a relationship with the state police. When we needed somebody to go to the city quickly, the state police would run point for us. And we could actually get people to the heart cath lab in Indianapolis before they could get their lab people to come in from nighttime. So it worked pretty well. One day, I went back to the office at noontime. That was kind of common to see what was going on. And they had a young lady sitting at the desk. She was extremely attractive. This is the late 70s. She had a low-cut top, a short skirt, and I figured she's got to be a drug rep because they're all pretty. Well, she was a rep, but it wasn't for the pharmaceutical industry. She worked for the American Heart Association. She said, "Would you like to volunteer?" I didn't know you could, but it sounded kind of like a good idea. I was seeing heart attacks every other day. I probably ought to get more involved in this. And at that time, American Heart was the largest organization of that type in the world. It still is, by the way. When they had their annual scientific meeting, and still, every October, they would draw 50,000 physicians from around the world to one city for 1 week. And it's quite interesting. The breakout sessions for education start at 7 a.m. and go until 11 o'clock at night. And Heart will have their own bus line going around to take the physicians to different venues for the various lectures. It was very interesting. Also, at this period of time, we started using advanced cardiac life support, ACLS. And up until then, physicians are taught by see one, do one, teach one. So you'd go in with somebody that actually knew what they were doing and learn what you were supposed to learn, whether it was a surgical procedure or putting in an IV or whatever. And the next time, you were expected to do it without supervision. Now, this wasn't ironclad. Sometimes you didn't learn things that quickly, and then we're going to turn a poor innocent patient loose on a medical student or something. But the third one was then, if you passed the first and second, you were supposed to train the third person. Well, things like heart attacks. How do you teach how to take care of a heart attack? And the answer is not easily. When you see on television code blue in an emergency room, an emergency procedure, it looks like everybody's running around with the proverbial chicken with the head cut off. There's no coordination to it. Well, actually there is. Actually, it's choreographed. And nowadays, when that occurs, everybody who comes in knows what they're expected to do during the code. So we had been learning up until this time by see one, do one, teach one, and that's not a good way to learn to deal with heart attacks. So American Heart Association came up with advanced cardiac life support, which involved a couple hundred pieces of equipment, 14 people, 3 or 4 days, depending how you put it together. And we ended up training 870 people at our hospital. I ran that program. That really helped a lot because now doctors didn't have to see one, do one, teach one, that we could learn the choreography in a rigid pattern. It worked extremely well. The advances in cardiology have been significant. We first of all had cardiac surgery, which started in the late 60s, early 70s. And surgery was done on people that had at least a 70% narrowing, because a 70% stenosis disturbs the laminar flow of a fluid, whether the fluid be air, blood, or water. And that got surgeons' attention. If the narrowing got to be an 80%, the surgeon was really interested. If it was 90%, he should have done surgery last week. And if it was a 95 or 100%, they're in the process of having a heart attack. So when I stayed with the American Heart Association, at one point in the early 1990s, I ended up being a national vice president. And one of the questions we had to answer, or tried to answer, was could you prevent another heart attack by using medications? Now back to the narrowings. The surgeon would fix whatever they had to fix. Say it's a 90% narrowing. They would then send the patient out of the hospital, and people like me were supposed to determine if the other narrowings around the heart, and of course there are multiple because it's a multicentric disease, were they becoming critical? In other words, was the person going to have another heart attack? Well, it's very difficult actually, because when people have had heart surgery, they change their behavior. Now sometimes they start going to the gym more frequently. Sometimes they simply sit in a chair because they're scared to death to have another heart problem. So it made the job of us, just watching, somewhat difficult. That's why the question came up, can you prevent the second surgery with medications? Now going back to 1948, Framingham, Massachusetts, which is right down the street from Boston. Framingham was invaded by Harvard University epidemiologists. Now an epidemiologist is a scientific voyeur. They don't touch anything, just watch. So they went into Framingham, and this was at that time primary practice, GPs. And the question they were trying to answer initially was, did the standards of care, the things the docs thought was correct, did they work? No one knew, never been tested. As recently as 1945, 3 years prior, there was a full-page ad in Life magazine of a surgeon in a surgical theater smoking a cigarette, and the caption was, "I recommend Camel cigarettes. They make you cough and clear out your lungs." Harvard has some work to do. By the 1960s, Harvard started publishing, and that's where we found out that high blood pressure, diabetes, smoking, and hardening the arteries were bad for you. Hardening the arteries, what caused that? Well, it wasn't hard to know what it was, because if you opened up the aorta or a bunch of other arteries, you could see what's called a fatty streak, the yellow streak in it, which was cholesterol. But they'd only started to measure total cholesterol in 1959, so they didn't have a whole bunch of information on what was a normal value. But they worked at it. And fairly quickly, they found out that total cholesterol was the wrong answer. The answer was a low-density lipoprotein, LDL cholesterol. Okay? So it took them 15 years, basically, to be sure that that was the right answer, or one of the right answers. It took another 15 years to try and figure out what the metrics were, what number you should have. They started at 170, then with more information went to 150, 120, 100, and right now, according to the American Heart Association, still the largest one in the world of its nature, and the American College of Cardiology, and that's every heart doctor in this country, the number is 70. Nowadays, we have injectables called PCK9s, and the one that I use is Repatha. It's an injectable medication, and it is incredibly effective, approved by the FAA, almost no side effects, and I've taken people from 200 down to 20. Well, if you have a cholesterol, an LDL cholesterol of 20, you can be fairly well assured that you're not going to have another heart attack. You're going to die of something, but it's not going to be that one. So the American Heart Association and American College of Cardiology published their findings, and that very much affected what we did in practice. It also affected aeromedical stuff. The FAA and the aeromedical medicine were started around 1958. They had a huge amount of information because they started actually around the First World War. And more pilots died in the First World War of training accidents because they weren't healthy than died in battle. So it was real pressure to those researchers at the time. How do you know that a pilot is healthy? Well, they kind of didn't. So right now, if you go to a textbook of medicine called Cecil's Textbook of Medicine, you'll have over 7,000 pages of basic medicine. Medicine has 135 either specialties or subspecialties. people like me and interns are lucky to have some knowledge of our own field, let alone anybody else's field. And aeromedical is the same thing. That's why they say that an aeromedical physician needs to be a physician, not an extender of care, a PA or something like that. And it has nothing to do with skills, because PAs and nurse practitioners are skilled, but they don't necessarily have a whole lot of experience. They're relatively young. When I was in training, we rotated through the specialties, surgical specialties, internal medicine, psychiatry. By the way, the rule in psychiatry is if the person in the room with you is nuts, you should have nothing between you and the door. So the person's nuts can be on that side of the room, and you should be able to get out. So the education of the physicians for aeromedical stuff started in earnest around 1958, 1959. But again, they didn't have a whole bunch of tools. They didn't have a whole bunch of laboratory stuff like we do now. They didn't have imaging of the heart or CAT scans or MRIs of the brain. They were really terribly limited. But they did have the ability to develop algorithms for treatment. If you see this, do this. Well, almost everything in the aeromedical field right now is based upon algorithms. If you go to a national in Oklahoma City, there are 15, maybe 20 physicians on full-time staff. There are also some more at the federal level in Washington. The physicians at Oak City have a front end, a cadre of folks, usually only 7, which answer the phone. So if I have to have an answer to something, I start off with calling one of the 7 people. We can know them pretty well. We know their kids. We ask them about the weather, because what's going on in Oak City is going to hit us in about 2 days in Indianapolis. And they're just nice people to talk to. They can answer most of our questions. I may even call them 2 or 3 times a day on a bad day. If they don't know the answer, there is a medical physician, or I guess, on duty. I was going with MOD, Medical Officer of the Day from the Air Force, but a physician there. They're good. They're overworked. They understand aviation. All of them are pilots. They understand medicine. Well, sometimes they're asked to come up with very unusual solutions to difficult problems. Remember, the reason there is an AME type situation is because Congress in the late 50s passed a law, a suggestion, that the FAA should keep pilots from having sudden incapacitation within the length of the certificate, the results of which could harm someone in the aircraft or on the ground. So actually, if you and I kill each other flying, or ourselves flying, shucks. But if you take somebody with you, that's really not proper. So the question comes up, what can cause sudden incapacitation on a pilot? Well, it used to be, 15 years ago, death, seizures, and fainting, primarily. We've had a huge change in the last 15, 20 years. It's now, this group of things includes going nuts. And going nuts is a big deal. You remember the 777, if I remember my details correctly, took off out of Malaysia maybe 10 years ago, ended up in the Indian Ocean. They never found it after several years.
Malaysian Airlines, yeah.
Yes.
I think it was 347. The guy intentionally crashed it in the ocean. They did the investigation. They see that he dropped coordinates in the middle of the ocean. There was obviously some mental health issues, but there was a very messy divorce preceding it. So whole, you were able to break down and see the investigation. This happened, this happened, this happened. Thus, here's the MO, this is why, right? It was not arbitrary. So the going nuts thing, and that's unfortunately post-accident.
He had a flight simulator at his home. He had actually programmed it in. And it appears as though what he did, he climbed to 40,000 feet, headed toward Russia, had the first officer go back and say nice things to the people in the cabin. When he went through the anti-terrorism doors, the captain locked them. Then he turned off the oxygen at 40,000 feet. Then he depressurized the cabin at 40,000 feet. And then he told the autopilot to take him to the coordinates you just mentioned. He knew he would run out of fuel, and he did. The one before that one was a little bit different. A young pilot in Germany flying 737s got dumped by his girlfriend. Broke his little heart in his late 20s, somewhere around there. So what could he possibly do except go kill himself? What other option was there, for Christ's sake? So he had to plan that out a little bit. Somewhere or other, he got control of the cockpit of a 737 and managed to fly right into the Alps at 7,000 feet, which is extremely effective.
It sounds like you're talking about the German wings accident, right?
It's exactly what it was.
Yeah, the CVR pulls up him breathing. The CVR pulls up when similar situation, locks out the FO from the cabin, and you hear him banging on the door, open this goddamn door. I remember that. That's all the audio's on there. And then you can hear the terrain warnings. It's such a tragedy. I mean, it's an evil tragedy to take people down like that with you.
Yes.
You know? Since that German wings accident, you ever notice that when that door comes open in the cockpit, FO goes to the bathroom, or the captain goes to the bathroom, the whole point is no one is unattended in the cockpit. You see the drink cart come up blocking, right? There's a little obstacle. It's good, some kind of prevention. And then you see the flight attendant go in there and close the door with the idea that at least there's not one potential crazy person in the cockpit, that the flight attendant could open the door for someone else, could at least try and fight him until she could open the door. But it's not one person with a door locked that could not be easily penetrated. So that's the reasoning behind the flight attendant scooping into the front cockpit.
Exactly.
Yeah.
Yeah, about 5 months ago, there was an incident on Alaskan Airlines, a 737 coming from Alaska down to San Francisco, and they had in the jump seat behind the pilot another captain, fully trained. He was supposed to pick up another 737 and go somewhere with it. Somewhere in the airspace over Oregon, he decided to put out the flame in the engines. There was no flame in the engines, but as you know, there are retardant systems, and once you toggle them, you're not going to start that engine again. Well, if you have a 737 and you toggle it for each engine, it became a very heavy glider. So the pilot and co-pilot took some exception to his behavior and beat him up. And during the beat up, he kind of awakened. He'd gotten into some psychedelic mushrooms a couple nights before, and he was having hallucinations. So they had him, because he now knew what was going on. He's a captain.
Yeah. This is somewhat recent.
Yes.
Yeah.
So he went back, he was told to go back to the back of the cabin, and someone would handcuff him to a seat or zip tie him. They did. The airplane made a emergency landing. The gendarmes came and took him away. And right now he's facing 83 counts of attempted manslaughter. He's lost his job. He also he was trying to steal an airplane. So whatever a 737 costs, it was kind of a lot. And he's lost, so far, his $1.2 million house in California, and probably his marriage and his children. Other than that, it was kind of an uneventful day. Fortunately, we don't see a whole bunch of that stuff anymore. There's two reasons for it. Number one, crazy people don't learn to fly. Number two, we rat each other out freely. If a pilot knows that another pilot is endangering folks, they're going to call it in. And of course, the FAA has an anonymous number you can call, and you just have to have the tail number of the other plane. But you don't have to identify yourself as such. Most of us want to, in case the FAA needs more information.
There's no real way to prevent the Malaysian Airlines pilot. There's no real way to prevent the German wings pilot from a aviation medical standpoint. It's essentially always having an FA come into the cockpit when someone leaves to go to the restroom. It's essentially having some kind of stopgap measure so they can come back into the cockpit. There's not one person in the cockpit locking people out. That's essentially the only antidote, which is already taking place? Because you see, you look at root cause analysis. What can you do to prevent this? And from the aviation medical standpoint, that's basically it, right?
There are things being done now to help pilots with things like depression, anxiety. Oh, in the last 15 years, there's been a whole bunch of effort to pick up ADD in younger pilots early on. ADD is kind of an interesting problem because the diagnosis did not exist until 1972 or thereabouts. And there's a whole bunch of pilots who you and I know that are ADD, a lot of attorneys, professional people, because unless it's ADHD, hyperactive syndrome, it just looks like somebody's distractible but intelligent. So going back to life on the farm, my mother was a teacher. One of the terrible things she had to do was teach 50 people, 50 students in 2 classes, 2 age groups, in one room for a year. Well, she was kind of up to that, but we had Tommy. Tommy was an ADHD. We didn't know it at the time. There was no classification like that. But Tommy would jump up from his seat, run around the classroom yelling, just being quite destructive. And my mother, before going to schools in the morning, would get a thermos of coffee. Nobody in our house drank coffee. So one day I said, why are you taking coffee? And she said, it's for Tommy. In the 1950s, somehow or other, people knew that if you give a stimulant to an ADHD, it slowed him down. But it took another 20 years to kind of put that into perspective. So now if a young person decides to go into aviation and they're honest on the 8500 form, and they better be because the penalties against them if they screw it up are significant. It's a $250,000 fine and 5 years in prison. They'll keep most of us pretty honest. But the question's asked, have you ever had an emotional or mental difficulty, ADHD, depression? And the problem with the diagnosis of ADHD is, since it's relatively recent, what happens when a mom can't keep track of their child who's an adolescent or pre-adolescent that's just very active, which is kind of normal at that range, but if mom really doesn't want to put up with it, they go to the doctor. What's the doctor going to do? Well, he doesn't have a test. There is no test for ADD. It's kind of a subjective thing by sending the person to a specialist and see what they think. Well, the doc, rather than having to do that, because there aren't many people around that they can send the child to, they'll use a trial of Ritalin or something like that. And when it works, it's quite impressive. When it doesn't work, it didn't work. But the child is now labeled. They have been diagnosed one way or another as having ADD. What if they get into the mid-teens and they have normal teenage behavior? They're moody. They're depressed. They get anxious or angry easily. Is that normal? Usually, yes. But it gets written down. It gets treated. Or not treated and just reported. So the psychiatric problems are significant. Not that they're terribly, really dangerous, although they can be, but there are multiple examples. Now, when the FAA needs to adjudicate something, they have these 15 or 20 physicians who usually, well, they're very good. They usually can come to an answer. What if they can't come to an answer? Well, one of the ways physicians are educated is with case presentations. That's when you get 15 or 20 docs in the room and the presenter says, okay, here's our patient. Gives the background, the symptoms, the laboratory, the x-ray and so forth, and the doctor's supposed to, in essence, vote. Now, it isn't in the FAA that they vote as to whether or not it's the right diagnosis. They vote as to whether or not it puts people at risk. And since they're using the algorithms, they're kind of tied to the algorithm. They have to go to the literature, and there are some exceptional books written on aeromedical things. Rayburn is probably the one used most commonly. And you can kind of look this stuff up. The problem is if I, as an AME, look it up, that has no force behind it. It's my opinion. If the FAA physicians do it, it's looked at differently. It's not a diagnostic choice, it's whether the pilot is going to kill somebody. We're still at the point that we don't have any way to nail down, say, personality disorders. If someone is schizophrenic, we can usually figure that one out. What if they're bipolar? Kind of, you can figure that out. What if they're borderline personality disorder? Yeah, well, you're kind of hanging because you don't have criteria to diagnose that. You see it all over the place. Some of my friends I've told that they should go to Wikipedia and look at personality disorders and start reading them. There's a bunch of them. And the Wikipedia is actually pretty good at defining what they look like. And then I tell my friends to sit down and figure out what their friends are. And it's kind of a good parlor game. No one knows if it's right or wrong, but it makes the people think. And I've done the same thing to my children. They're now adults. So they've been schooled in personality disorders to some degree, because if they're going to work in the real world, they should be able to figure out if people are suffering at that level. Personality disorders, kind of if they're nuts. In the FAA, again, it's a very difficult thing. Now, what if they come up with an adjudication and the pilot doesn't agree with it? Think, that's wrong, that's not me. Well, they can go to another physician and see if there can be documentation, testing or something to change the diagnosis. Commonly there isn't. Every once in a while they'll call their senator. Don't do that. As soon as a senator calls and disagrees or wants an explanation of why their fellow didn't get approved, that means it's going to have to go to the federal level, Washington, because that's who senators talk to. Well, Washington level, they're going to overturn the FAA at Oklahoma City? Of course not. They all know each other. And these people in Washington are not expected to know all the stuff that doesn't occur at the Oklahoma City level. And they aren't expected to redo all the testing. So what are they going to do? They're going to reject the appeal. There are people in the United States, probably a half a dozen or a dozen that I know of, that are AMEs that specialize in difficult cases. The one that I use is in Philadelphia, or Pittsburgh. And he has 30 years or so of being an AME. He's a specialist. He's got 18,000 hours of a captain in a jet. He knows the people at the FAA level personally. And so he can call them up and talk about the case mano a mano and come to maybe a different decision. He's very good. But there's not a whole bunch of him in the United States. There's a group in Denver, Colorado that is quite good. I'm sure there are others around that I don't personally know. But if you have to fight a decision from Oak City, that's the path you take. Don't call your senator.
When you have pilots come in and do a medical examination, they fill out MedExpress, you review it, you can approve it, you can defer it, you can reject it. About how many people do you defer? Do you reject any?
I have never rejected a pilot yet. I've had one I almost rejected who came in screaming at the staff. I'm not quite sure why, but we actually had called the police to come and get him before he left on his own. I called that one into National and he is no longer a pilot. Deferrals. We probably defer 5 out of 100. It's not high. And most of them end up flying. So the FAA is very proud of the fact that their job is to keep pilots flying, not to dissuade them from flying, for two reasons. First of all, they are also pilots. They want them to fly. And number two, if you just get rid of all the pilots, what's the FAA going to do in the medical department? Not much, because there aren't any pilots around.
Yeah, we assist people in the setup and the onboarding for flight training with MedExpress. And I think I've only seen 3 or 4 deferred. And there was a guy, once again, like you just said, it eventually gets approved. He had 3 DUIs 20-something years ago. Was honest on the application. So it's basically an automatic deferral. Goes through the process. What I want you to kind of tell us more about is the HIMSS process. So these DUIs that he got were 20 plus years ago, but they still happened. And he got his medical. It took him about 18 months. What's happening behind the scenes? Someone has a DUI 2 years ago, 5 years ago, 25 years ago, 2 or 3 of them, 1 of them. They fill out MedExpress. They go see the AME. They go see you. Hey, this gets deferred. What happens with Oak City? What happens with, what is this HIMSS program? What happens regularly from that first office visit to 18 months, there's a medical certificate issued? Is that a special issuance as well?
It is, yes. There on the internet is an AME guide, G-O-I-D-E guide. It's about 400 pages, and it's everything that we use in as a textbook. HIMSS comes out of that. And basically, HIMSS is a subspecialty that isn't found in the regular medical world. It's in the FAA world. And it's to make sure a pilot isn't nuts or an alcoholic or abusing drugs or. So it's still an algorithm. But you end up with the HIMSS physician early in the algorithm, not late, because they want to make sure they haven't made a mistake, they being Oak City. HIMSS physicians are us, but they've had some extra training in drugs, alcohol, psychiatric problems. And their job is to, first of all, decide if this person is dangerous. And if not, then there's going to be some sort of remediation, like Alcoholics Anonymous, that type of approach. By the way, the HIMSS was started, many years ago, 35 years ago. And TWA and a couple of other large groups were finding out that if they had a pilot who was an alcoholic and they had to fire them, at that time it would cost you about $100,000 to find a new pilot. To put them through therapy was about $10,000. So the large corporations in aviation decided to do it that way, and then the military decided to do it that way, and then the FAA decided to adopt it as a norm, and that's where we are today.
What about, there's a stigma in law enforcement, aviation, military. Like you mentioned, someone has depression, someone has problems, they want to talk to someone. There's a common understanding, any kind of psychiatry, any kind of counseling, that would lead to an automatic deferral. Or if someone has a medical certificate and they go to renew it, it's no longer just going to be a 15-minute appointment and get issued. Is there a different approach now with mental health and counseling, at least in aviation, from what you've seen as an AME?
Absolutely. The reason the deferrals happen in the front end is because, well, analogy. You hit your thumb with a hammer. How bad does it hurt? Is it a 1 because it's a glancing blow, or did you break a bone? Well, if someone comes down with depression, how bad are they suffering? How badly are they suffering? And so someone has to figure that out. And until they do come up with an answer, it's going to be deferred. Now, the FAA absolutely wants pilots to fly. This has become more of an issue with a PTSD. PTSD is well recognized as being something, a complication of war. But it's not only war. Medical personnel get it. Law enforcement officers get it. Firemen get it. It is not uncommon at all. And there is treatment. It's not very good treatment compared to the other things, like anxiety and depression are pretty straightforward because we know the biochemical reason for it. PTSD, not so much. So it has to be treated on a one-on-one type thing, and the HIMSS will almost always get not a HIMSS person involved, they just send to another person who's an expert in PTSD. The VA has become both good and bad in dealing with PTSD. They recognize it, they treat it, It's like tinnitus. If you find a previous military person and they're on disability, they almost always have a 10 or 15% disability because their ears ring. Well, that makes sense. Jet engines, rifles, and so forth, that'll make your ears ring. They get a disability for it. How about PTSD? Yep, they get a disability for that also. But that one is disqualifying for flying. So you either have to say, well, it was a wrong diagnosis. That's hard to do. Or say, well, they're really better, which at my level, they still can't do. Or go to the VA and say, we need clarification, which is almost impossible to do. Because when the VA classifies a veteran as having a disability, who's the court of last resort? It's the VA. And they're not set up terribly well to rehash previous diagnoses because the FAA doesn't like it. And the FAA and the military don't really get along terribly well. They all have strong personalities at the higher levels, and they're not going to say that their people made a mistake. So it remains to be defined how that's going to work out in the future, but at least they're working at it.
What are the different types of color vision testing that happens during a aviation medical exam?
Good question. We had color books called Ishihara, another one called something else, and we had Farnsworth lamps, which was a projected color going through lenses, and they don't exist anymore because the FAA did research and came up with one test, which is called the Wagoner, W-A-G-G-O-N-E-R, and the Wagoner test is computer-based. So in our office, we have an iPad that we put on this. So we downloaded the Wagoner to the iPad, and it's the only thing that we use now. It's the only thing we can use now. So let's say person does not pass it. Well, then we can still issue, but it's in our form, it's number 104, which means basically you can fly during daylight hours, but not at night. There's some other things about flying with reference to lights, but I've never seen that one that wasn't at night. And just for the interesting part of it, in the thousands of pilots we've seen, I've only seen one that ever flew by light guns. And it was on his very first flight as a student, and lost the radio and NORAD, and the instructor had to set the transponder and then wait for the light guns to come on. But it's very uncommon. Now, the obvious question is, what if you don't believe the test is correct? But you can do a physio type challenge, and you call the FAA and say, I want to have a light gun or colored test. And they'll say, okay, and they'll give you the information you need to go to the FSDO. In our case, it's in Indianapolis, and there'll be somebody there that is especially trained to check you on light guns. Now, light guns use incandescent bulbs. What about if you put an LED in there like the top of a police car? You can see it a year away. We don't know yet. Hasn't been done yet. And the reason in our state is because no tower has wanted to spend the money to get that kind of a gun because they don't use it very often, maybe almost never. And they have a limited budget. So putting a couple $1,000 into that kind of a light gun kind of doesn't fit their operational requirement.
Someone gets deferred. They totally fail all the color vision testing during a pilot medical, and they can go for a SOTA. Can you explain the SOTA process?
SOTA is a statement of demonstrated ability. We have one gentleman who was using a rotary saw and managed to cut his left hand off. He was close to a good hand surgeon hospital, and they put the hand back on. And it actually works amazingly well. And he is a captain, but he's now a captain from the right seat, not the left seat, because they had to have him do an operational test and found out that some of the controls he couldn't reach without being in the right seat. So he's still captain, but he's a right seat captain. The only one that I know of that does that. But a statement of demonstrated ability is something that isn't going to change. Something that is going to change is, say you have a special issuance for heart disease. Well, it's probably not going to be fixed forever. It's going to change one or the other. So that one is a special issuance, not a SOTA.
And for the folks that bust the color vision tests, which from what I understand, a large percentage of males have the red-green deficiency. They bust the medical for the color vision testing, and I've seen it here and there where they'll go out with a DPE that specifically is qualified to administer the SOTA. They'll go to the non-movement area, call the tower, give them light gun signals, red, white, green. Hey, you passed. And the DP is not issuing the certificate. They actually are making a recommendation, then it goes back through Oak City, and then it lands on your desk. And then when you get it, what is happening there? You saw the process from the start to the finish. You've got the recommendation from the DPE. Oak City saw it, and then you issue it, or what is the guidelines? What happens there at that last step?
I've never had it happen. The SOTAs that I've run into, Oak City actually issues. So they don't get me back into the loop because basically I'm useless at that point. What am I going to do? Say yes or no? I'm not going to say you're wrong. And I've already said there's a problem. So I don't know what's going to happen with this new Wagoner test.
But before that, the issuance would come from Oak City. So the
That's
recommendation would come from the DP, and then what would the medical certificates do? Just an arbitrary flight surgeon name from Oak City? Is that who'd issue it?
Oh, there will be a special issuance. Special issuance has a PI number. It's a 8 or 9 digit identifying number. It's kind of like a Social Security number because it doesn't change. And it will be on a form that comes to the doc. First of all, it goes to the pilot and the doc at the same time. And a special issuance letter, no matter what it's about, is the same thing. It's a boilerplate letter. The first paragraph says, son, you ain't never going to touch an airplane the rest of your life. Paragraph 2 says, but by the grace of the regulations, I can change that. Paragraph 3 says, but to change it, I need this documentation, which would be the DPE. And then 4, if it is a special issuance that might change, like heart disease, it says you have to do this type of testing every year or 2 years, whatever the frequency is. It's different for different things. For the SOTA, you don't ever have to be retested. Once you're done, you're done. If the pilot nowadays has ever passed any kind of a color test, they don't have to do it again. Never. And the reason is that's a genetic illness. Now, I've seen people that I do not understand that seem to develop color issues as they get older, but in terms of issuance, that doesn't appear to be a problem. There are books written on the different kinds of color deficiency, that's what they're called, and quite honestly, it's out of my field.
It came into effect January 1st, 2025.
Exactly.
And as of January 1st, 2025, there is no color vision testing occurring with the book anymore.
That is correct.
It's all happening with that machine.
Yes.
And if someone's already passed it, then do they still have to do it every single year?
Never. They're done.
How did that come about? That's a huge like game
It is a
changer
huge
for a lot of people.
And FAA has been working on this for a couple of years. The Wagoner test actually was developed at the request of the FAA, as I understand it. There are other federal groups that accept it, or actually use it, but FAA is the one that we run into.
I had a student that, well, actually, I have one student that amongst all of the students that have ever had a deferral and they've all gotten their medical certificate, I've got one student that years ago, he took Ritalin, like you mentioned, the 12, the 13-year-olds, whatever, discontinued it, was honest, put it in his application. He's going through that process of getting a special issuance. Medications like Ritalin or any others that you can mention that, you know, aspiring pilots have taken as a child, what is the process from start to finish? What happens? What's the likelihood? How long does it take when they put it on MedExpress, they go see the AME, hey, this is going to Oak City as a deferral, and then they get issued it. What's happening? Are they doing psychiatric evaluations, and how's the approval process? What would lead to it being totally rejected? What have you seen in your experience?
Again, excellent question, because it's based upon why something was deferred. Was it the disease state or the medications used to treat the disease state? For example, schizophrenia, it isn't going to go away no matter what medication you use. So it's the disease state. Anxiety, the medication is used for the symptom control, not because the underlying disease is necessarily terrible. In the case of ADD, Ritalin and so forth, or almost anything that happens in that age group, which you start off assuming it was an incorrect diagnosis. And if they were given Ritalin for, say, 6 months, the question is, did it make them better, or did they notice it at all? And applicants are pretty straightforward on that one. If it didn't help them at all, they'll say it didn't help me at all. Well, that's common because there is no good way to make the diagnosis of ADD. Depression, anxiety are conditions which, with counseling, with age, should get better. By the way, ADD gets better not because it goes away, but because people learn to use a cognitive skill to deal with it. So you have people, physicians, who take no medications now, but they used to. And it's terribly interesting because there's an age group here that are concerned they're getting Alzheimer's disease. Really? Well, we don't have a good way to diagnose that either. We have ways to diagnose it. As of very recently in Sweden, they came up with a blood test to check for fibrils, teofibrils, in a blood test. Up until this point, we could have 2 different ways of getting spinal fluid, but you got to stick a needle in the spinal column, which isn't hard to do, but most people won't select that. Or you can get a very expensive form of an MRI of the brain. And this new blood test is going to be extremely important. Why? Because until then, companies such as Eli Lilly in Indianapolis, Lilly's been working on something for Alzheimer's type dementia for a long period of time. Dementia may have 8 or 9 different types. The Alzheimer's is the one that we're always concerned about. And until they come up with a good blood test, which they probably have done now, but it's recent, it's hard to do clinical studies because they don't know if they're testing the right people because they don't have a test for the diagnosis. This has been a major stumbling block for the large companies.
Have you seen any kind of changes in pilot medicals since the COVID-19 vaccine? Meaning that pilots that have taken the COVID-19 vaccine, have you seen them get sick in the cockpit, sick period, any kind of thing that you've seen in your office?
I've not seen it, but I believe it.
What are your thoughts on it?
COVID was an mRNA virus, and there are people, the Surgeon General of Florida is MD, PhD, as best I can remember, excellent credentials, and he basically told the state of Florida to kind of ignore the restrictions that were put on federally. He happened to be correct, because things like distancing, the 6-foot rule, that was stupid. They made it up, and they now admit, they've admitted that it was made up. Should have been 3 feet, 6 feet, and actually the Scandinavians that came back to the research table, 2023, and said the actual distance is 16 feet because of droplet spread. But the real issue was hand washing. When this started out, I couldn't get masks for the office for 6 months. I actually called the governor of Indiana, who was very sympathetic, but he couldn't get them either. So my one mask came from Menards. That was it. I wore it every day for 6 months. Did it make any difference? No, but washing my hands a lot did. So it's the same thing as you see in the flu season, the bad cold season. Wash your hands a lot. And that seems to work pretty well. Now, what about other viri that have not yet been typified, maybe not even discovered? We don't know. We don't know. It's a scary thing. There's a whole bunch of viruses that have come out of the dark continent of Africa that are deadly, but we don't have any treatment for them. And fortunately, whether they came primates or from where, they tend to kind of die out in the population. Now, as we all know, the COVID virus was man-made. It was made in the Wuhan laboratories, and it was supported by United States research grants. The fact that they said it came from a bat in the wet market was stupid, because it comes from a size bat that they didn't have in the wet market, small ones. You don't need small bats, but we eat large bats. So the fact that they were trying to pin it on a bat was not sensible. So they wanted to say it was a species jump, and of course that was ridiculous. It started out affecting the first 2 people were from the Wuhan lab. Now, that didn't get spread around, because who wanted to talk about that sort of a topic? All the world did, except for the people running the research lab. Some of the refrigerators there, when they were finally examined, didn't even have rubber seals that were working on the doors, so you could have airflow through there. Which brings up the question: how do you trust any authority? Don't know.
Do you think there's any link to several instances, many instances of early on pilots taking the COVID-19 vax and then dying later on in the cockpit, a week later, a month later? What's your thoughts on it?
I absolutely believe it happened. I don't know about the cockpit, but in terms of disease causation by the shot, yeah, I think that really, really happened. mRNA viruses, first of all, the vaccine itself wasn't pure for an mRNA. It had parts of DNA in it also. So what kind of immune mechanisms did that trigger? We have all kinds of immune difficulties. Lupus erythematosus is perhaps the prominent one, but there's all kinds of them. And more developed all the time, because we're learning more about the epidemiology of this kind of a disease process. And maybe that the shot is a disease process in its own right. I'm not saying it is, because I really have no idea. But some real bright people are working on it. Because if it is, the pharmaceutical industry can't be trusted to do testing on their own, because they didn't test for it. There's all kinds of rumors about a collusion between the pharmaceutical industry and the government and so forth. Could be. Probably 10 years from now, researchers or the government committees out of the House and Senate will actually come up with ideas. Who would you believe now? I don't know.
What year did you become an AME?
2002.
And then you were already a flight surgeon in the Air Force preceding that.
I was an internist in the Air Force, not a flight surgeon.
Okay.
I did intensive care work.
And once you got to Oak City to go through training, become an AME, what was that like? What was the fun of it? I've had AMEs tell me it's cool going in there and you get, put in the chair and you start spinning one way, you have the foggles on, and then you say, which way you're spinning? This way, you take the foggles off, and then you as the AME get to see, because not all the AMEs are pilots who get to see what is spatial disorientation. This is what spatial disorientation
Now, flight surgeons go through that.
Yeah.
We don't. Ours is lecture. One of my partners is from Michigan, and his name is Greg Pinnell. And Greg, he and I went through the astronauts training center in Texas, and they had this spin the heck out of a pilot long arm centrifuge. It's not a centrifuge. Anyway, it'd spin you. And so in passing, I said, "You ever ride in one of these things?" He said, "Yep." Twice. I said, how was it? He said, it's the worst thing I've ever gone through. And he's in his 60s now, and he's a very competitive tennis player. He's got all kinds of good credentials. He does high altitude research. And for him to say it was the worst thing he ever went through is sobering. I can't imagine people would do that. He had a dead man switch. That's how they run the thing. But he'd already passed out at about 9 Gs. He wasn't awake enough to let go of the switch. So they got him up to, around 11. And then somebody said, it's too much. So they shut the thing off. They pulled him out of the machine. But I wouldn't want to go through it.
Jesus. Was there, being being in the Air Force and being in medicine, and then having your practice, becoming an AME, was there any kind of pivotal moment in your medical career thus far where you said, hey, I'm going to go this direction, or I'm going to go this direction, or why?
Yeah. The first one, it was very instrumental, pivotal. We had a representative come in and say, you ought to put a computer to run your office. Well, there were none. But this person worked for the NCR people, cash register people, but they also had computers. And I thought that was interesting, so I had him come in and talk to us. And they said, well, the program we use, the software, is written in COBOL, which is an ancient programming language.
It's on the big mainframes, yeah. Cobalt, yeah.
So they said, this lady is a PhD in medical economics. I didn't know there was such a thing. And her son was a brilliant young man who actually wrote the program to run a medical office. And she was lecturing in the United States about medical economics. She got involved with the computer because of her son. And we had just purchased one to run our office. So I got a knock on the door and said, would you like to lecture on computer applications in medicine? Well, I had just purchased a TRS-80 computer. I was coming back from Florida one week. I'd been down there for a meeting, and in the Newsweek magazine it said Radio Shack is going to be selling a computer. So I knew Bob that owned the local Radio Shack. I would go and say, hey, Bob, I'd like to buy a computer. He smiled and said, Stan, we don't sell computers. So I showed him the Newsweek article. He said, oh. The next week was a national sales meeting in Chicago, and he went up there, and I have one of the first 100 produced in the world. So we were learning to program TRS-80 in basic code, and we weren't any good at it. It wasn't anything. It was just a learning experience. But I now had a computer and ran one in the office for the office, which actually worked extremely well. So I became an expert in computer applications in medicine. So I joined the speaking circuit. There were 4 of us, 5 of us. I was the 5th one. We went to various places for multiple years, and we lectured to over 5,000 physicians on the various things that we knew that they didn't know yet. Now that young children know more than we knew. But the first lecture we had was in Chicago, and went in, and there were 500 doctors in the audience. Well, as I was starting to use the K-Pro was an old transportable computer, used CPM media language, and I had an old primitive tone in modem. The one that goes, shoo, that kind of sound. You may never have heard one, but that's what we use. So I hooked it up and asked them in the audience if they had anything they wanted me to research, because I was in the National Library of Medicine database. And someone said, yeah, DRGs. Now, a DRG was the primitive way of controlling medicine from the government many years ago. Disease-related groupings is what it stood for. And we use it every day in the hospital. Not very helpful, but I put in DRG and I got over 10,000 hits in a couple of minutes, or less than that, about a minute. And it turned out the DRG is also a dorsal root ganglion, part of the spinal cord of a mouse. So I got 10,000 hits about a spinal cord of a mouse and nothing about disease-related groupings. And the lesson there was narrow your search down. So we learned a lot with the initial lectures. And when I ended up at the American Heart Association, I ended up speaking to a large number of people in various places because I'd kind of learned to do that because of the computer. And when you don't have a clue what you're talking about, but you know more than the audience does, it's easier, I think. So that was the first pivot. And the second one was going into cardiovascular disease prevention. There was a time when we had no idea if you could reverse hardening of the arteries. And again, we found out that you absolutely can. And the key to it all is LDL cholesterol. The real key is getting the patient's attention. Because if I tell someone, hey, you'll feel better and you'll live longer if you do thus and so, sure. If you get a new Buick, it just doesn't work that way. So we didn't have anything to modify behavior really, except education or fear, perhaps. Along comes coronary artery imaging. And the coronary artery imaging is done with a CAT scan. This isn't like a heart cath, but it's a scan, and it picks up calcium. Well, anytime you have something in the body that irritates the body wants to make it into bone. So like tuberculosis in the lungs. In southern Indiana, in the old days, 20 years ago, you'd have a young person come in and they would have calcium shot through both lungs, and it wasn't TB, it was histoplasmosis. And the reason was it came from pigeons in barns, and back in those days, the younger people worked in the barns. Nowadays, they don't go out, they're not farm-based anymore, so they don't go to barns. So they get the histoplasmosis from the pigeon droppings, and they didn't have any symptoms, so they come in and we pick it up on a scan. Well, if you happen to have heart disease, it all starts with inflammation in the coronary arteries. And it's the cholesterol, but the cholesterol causes it. There's actually 35 causes of hardening of the arteries. 34 of them are not cholesterol. So 2 decades ago, some real bright people wanted to know what the common denominator might be. They had to have some sort of common denominator. Turns out it was inflammation of the wall of the artery. That's why the body tries to put calcium in it. Well, when you run a CAT scan over the chest, you'll see these spots of calcium light up in the coronary arteries. And if you get more than 100 hits, you figure you have a real problem here. I've seen people come in with 2,000. And even at that high level, given the right treatment, they can reverse the process. The inflammation can go away. And nowadays we can measure the inflammation with blood tests. So I got involved in trying to figure out how to not allow pilots to get sick. And it starts out with the routine, the 8500 form. You find out a lot on it. And you try and follow up the ones that are really important, but not necessarily during the AME exam, because having a risk factor for heart disease isn't one of the things the FAA is concerned about yet. They may be for a bunch of reasons. One is the pilots, if they put the retirement age for commercial aviation up to 67, how are you going to screen those last 2 years? Because that's when people have heart attacks. Do they all have to have a heart cath or a treadmill or an angiogram? We don't know, because it hasn't happened yet, and it may never happen. But when I'm done talking to them about the 8500 form and do an examination, there are 2 questions I'm going to ask them. Number 1, if you're over 45, are you up to date on your colonoscopy? And number 2, what's your LDL cholesterol? Now, they kind of know whether they've had a colonoscopy or not, but they don't have a clue what the LDL is. And the reason is, let's say they had lab drawn. And then they go in and the doc says, oh, it's a little bit high, but it's okay. Is that real? No. The number must be 70 or 40 is the one that I believe is true. And being almost okay doesn't count. Why? Because you don't know when they're going to die. Let's say you have someone who comes in and they're going to die of something tomorrow. Well, there's a whole bunch of stuff you don't care about. One is LDL cholesterol. If you change it, they're not going to live beyond tomorrow because that's when they're going to die. What if they're going to live to be 97 and they're 50. You got 47 years of risk. So then you have to remind the people that being healthy is a risk factor to their health. Because the healthier you are, the longer you're going to live. The longer you're going to live, the more the slings and arrows of life are going to hit you. Something might happen. Can you prevent it? Commonly, yes. So what happens to pilots? 29% has to do with coronary artery disease. And next one down is some sort of cancer. If it's a female pilot, certain types of female cancers, a male pilot, male cancers plus colon cancer for both males and females. Well, you can screen for those. So the heart disease you can reverse with medications. The cancers you can make kind of go away, but if you wait too long, they get to spread to the liver, and now you got a real problem. Accidents is the next one on the list, but it's not airplane accidents. It's falling off a ladder accidents, things like that. And there's a whole bunch of things that are in the CDC database for what happens to people by age, sex, and race. And I don't tell pilots all of this because it's not important to them. But they have to understand that they have to deal with the risk factors. That's the internal medicine part, which has nothing to do with flying an airplane.
What's the weirdest case that you've had in giving a pilot medical in the examination?
Pilot medicals are just downright fun because in my 50 years before that, the people I saw were either dying or because internists are kind of like the infantry. You see everything at the emergency room level or maybe later on when they're not doing real well at all. But it's actually kind of like work. When you're dealing with pilots, it's kind of like fun. First of all, pilots, as you know, will never complain about anything. What do you mean my hand's missing? I didn't, that kind of thing. They're going to use denial, which in itself is an issue. But they're happy, and as soon as they find out that I am on their side, I won't let them fly and hurt somebody. That's not the way I'm on their side, but I want them to be healthy and live a long time. Then their sense of humor comes out. And as you know, pilots are inherently pretty happy, humorous people. That's kind of what goes with the genre. And that makes it just fun. So the major shift, pivotal, is I've become a preventive physician for pilots because that's what I used to do as a American Heart Association, what I used to do as an internist, and it's something you can measure. If they come in the next year and they've had their colonoscopy done, they had a cancer taken out by having it snipped out, cool. It didn't end up in their liver. If they have their LDL start out 200 and it's now 40, that's cool. So you have an endpoint that you can measure.
Talking about being a preventative AME, that's pretty innovative. What kind of checkups, what kind of testing should pilots do to increase their longevity, based purely on statistics? I know you're a big stats guy.
Yep. Well, you start with the big three, which you can definitely affect. Now, the subcategories of those three, for example, what tests you want to do for the heart. There's all kinds of heart tests. The ones that I now use the most, I used to do treadmills. I've done thousands of them. I put in heart pacemakers for years. That's not something that pilots have to worry about. But the other risk factors, they do have to worry about. And they're almost all reversible. I realize I'm repeating myself, but I repeat myself with pilots also. Because they will use, we all use, denial as a coping mechanism. Well, it won't happen to me. Well, something's going to happen to you. And if you can see a train coming down the track, step off the track. It's not rocket science. But they don't know what tests to get. So you start out with a colonoscopy and blood tests. There are a whole bunch of inflammatory markers you can check for in the blood. We check for diabetes. If their blood pressure is up when they come in, I make the assumption that it's real. Now, is it usually? No. The way you're supposed to check blood pressure is after the person's been lying flat on their back for 15 minutes. Then you go check their blood pressure. We don't do that. The day isn't put together like that. It should be, but it isn't. EKGs are an historical thing. They tell you what happened before the person walked in the office. They don't tell you a thing about what's going to happen when they walk out of the office. So an EKG does have some ability to project into the future, but not much. In the aeromedical texts, the first 100 pages has to do with the various things of cardiovascular disease, valvular disease, hardening of the arteries, rhythm abnormalities, and so forth. It's all in the book. Now, it takes a while to read the book, but it's in there. So if you find something and you send it out to Oak City, they've read the book. Right? They wrote part of the book. They're pretty bright out there. So someone will figure out those things. But the rest of the things that can happen can be severe. Rheumatoid arthritis. Can you still fly with it? Yeah. Cancers, can you still fly with them? Yeah. Have to have a special issuance. But the actual flunking rate is pretty low, and most of the other is to try to discover things before bad things end up happening to them.
Have you ever encountered a applicant that you think poses a risk that shouldn't get a medical?
Yes, but I haven't known them long enough to see if that risk actually ended up happening. Heart disease is the one I worry about. Having a pilot that's PTSD, I worry about that. Depression, anxiety. But what you normally see, not only in pilots, but also in general medicine, and again, I've seen about 500,000 people. They'll come in for an internist with heart disease, diabetes, high blood pressure, stuff. That's what you deal with. What's really troubling them? Their soul. Bad marriages, bad finances, bad judgment, bad outcomes. And that's what they'll end up talking about, but not right away.
And then for those that have to go through the HIMSS process, what's that process like for someone that had a DUI in the past, or have you ever encountered someone that has a medical and got a DUI while they have an FA medical certificate? Have you encountered that?
Absolutely. I had a gentleman, delightful pilot. He and his co-pilot were flying a Falcon. They flew it into Vail with the people that owned the Falcon. While the people that were owners of the Falcon were out doing whatever they do, the pilot and co-pilot went to the bar. They ended up getting pretty well drunk, and they actually got into a fight. And the co-pilot knocked the pilot backwards. He hit his head on the cement. The Vail Hospital didn't know what to do. Well, they knew what to do with it. Send him to Denver. That's what they did. So it was an emergency trip to Denver. And when he got there, he'd had a concussion. It was quite severe, and a skull fracture. So he got deferred because of a neurological deficit. You have to go a certain period of time after that before you can apply for another medical. He did that. And as he was going through, they flunked him because he was an alcoholic. Actually, he was. But they picked it up because of the 2 or 3 prior alcohol-related incidents. And so he's now having to go to the HIMSS. And the HIMSS is kind of like Alcoholics Anonymous. There's going to be a sponsor. That's the doctor. And the doctor's not actually sponsoring the HIMSS doctor. They're paying attention, making sure the pilot actually does it. And as long as they cooperate and go through the protocols they're supposed to, which are, again, an algorithm, they can probably get back to flying. But the alcoholism is considered a huge deal. What kind of personality disorder is behind an alcoholic? Several. And they don't want the personality disorder flying the airplane any more than they want a drunk pilot flying the airplane. So the HIMSS doctor ends up being a referee, if you will, to making sure they show up. And as long as they do and fulfill their special requirements, special issuance requirements, they can get back into the cockpit. And that all comes from the TWA type folks who found out it was cheaper to rehabilitate somebody than it was to start over.
Work-life balance. You have any suggestions for pilots that, besides diet and exercise, professional flying today is so demanding, especially not just corporate flying, airline flying, flight instruction, bush flying, all the above, where the day goes by so fast where you can just get into a quick meal, sleep, repeat. Any suggestions on time management where for longevity, where you don't develop medical problems later, in the preventative, in the preventative mindset, any work-life balance suggestions?
It's incredibly important, and I haven't figured it out myself. Back in the old days, I worked 100-hour weeks. I didn't see my kids grow up. They had a wonderful mother, and they turned out to be awesome. But I didn't have much to do with it. I wasn't home. So between being absent from the home structure and being so tired I couldn't walk, that was a huge mistake. I also put 20,000 miles on a road bike. I used to race bicycles. And so that was kind of my stress reliever. Go ride 100 miles and see how you feel. After about 20 miles, you can't remember a thing that you're worried about. It's gone. So exercise, whether it's a gym or a bike, something else, is mandatory. We now know about enkephalins and endorphins that are released from the brain with certain types of stimuli, and they're good for you. Morphine is basically in that category. So it's one of the reasons people get addicted. Addictions. Addictions to alcohol, to smoking, to sex. There was recently a Discovery Channel specialty on how the brain lights up with sex. And I was entranced by that one. How do you figure that one out? Well, they used functional MRIs and all kinds of things. And the parts of the brain that light up with sex are about the same ones that light up with a drug addiction, gambling addiction, they're extremely potent parts of the brain, central brainstem. And that's a problem. Because if you have something that is really giving the pilot a reward, and you tell them not to do it because it's bad for them, lots of luck. Because the brain is lighting up from the reward that they're already getting from something that might have bad consequences. And I see it's far more suffering from the emotional part of a pilot than from the physical part.
Yeah, I mean, it makes sense. That's where your dopamine rush is coming. That's where the oxytocin is being released. So it's pretty simple. It's not some magical, innovative answer. It's sparingly. Sparingly this, sparingly that.
Absolutely.
Rest, diet, exercise. There's not some rabbit we're pulling out of a magic hat with some, oh, that's what we're at.
Exactly.
What do you think are some medications that are okay for pilots and things to stay away from? You know, the FAA is very clear. Here's approved medications, here's not approved medications, but how many people are reading those lists, right? What are the big ones that you see? Hey, this is okay, but this is a no-go, stay away from this. Any kind of suggestions?
Almost all medications are okay, except people have depression. There's 5 different antidepressants that can be used conditionally. You still have to report it to the FAA, but they will probably approve it unless there's an underlying character disorder, something is worse than what they're seeing with depression. Anxiety, don't use in the cockpit. What about when your daughter's going on a first date with the boyfriend? Should you take an Ambien or something like that then? Maybe. Or keep a gun next to the front door, something to dissuade the young man. But even people who use Ambien, if they don't use it within 5.5 half-lives, it's kind of theoretically okay. Now, the feds don't say that, but it's based upon the half-life of a drug and the elimination time. The half-life is how long it takes half of the dose to be metabolized. Think about the hole inside of a bucket and you put water in it. The half-life is how long it takes the water to drain out through the hole. The next half-life is how long it takes the rest of the water to drain out by half. 5.5 half-lives, the drug's going to be gone. Half-life is usually the dosing interval. So if the dosing interval is every 4 hours, 5.5 is what, 20, 22 hours, thereabouts. If it's like the first antidepressant Prozac, which was a week, that's a long time, a 5.5 half-lives. And ironically, Prozac is as best my memory is allowed nowadays because, except for having a long half-life, it isn't dangerous. Now you want a long half-life if you're using a life-saving drug. Well, depression is a deadly disease, so in the old days we thought if it's going to be around for a long time after you stop it, in other words, it lowers its own blood level by metabolism. Maybe that's a good thing, yeah, maybe. The big thing with the feds is to make sure they're treating either to define if they're treating the condition or the medication used for the condition, or both. And that's a case-by-case deal, really. Something has basically no half-life issues and no medication problems is Tylenol. Can Tylenol kill you? Oh, yeah. It's the #1 drug used for suicide in England because they don't have guns. So if they take 1,000 Tylenol, it's going to wipe out the liver. And that's a problem because they're going to die, but they're not going to die quickly. It's kind of a prolonged suffering death. And that's the way you die in England.
That's the #1.
#1.
I did not know that. With medications with pilots going for medical exams, is there a state system? Is there a national system, like a database where it shows what medications pilots have taken, been prescribed? How does that work?
No, there is not. And the way the system works is the 8500 form. You know, if you lie on it, $250,000 and 5 years in prison. That is a pretty good system, but it's primitive. Could you get it out of databases? Yeah, but who has the time? In internal medicine, the average number of medications were like a dozen, because no one comes in with just diabetes. They've got a whole bunch of stuff because they're not healthy. So if you go to a database search for like 2 medications, like a pharmacy does, they'll say you shouldn't take these 2 together. Okay, I got that. What about these 4? Can you take them together? The combinations and permutations of mathematics, that's an infinite number. So you don't know what the combination of medications is going to do. You do know what 2 of them or 1 of them might do. So the government, the feds, have no way, realistically, until they get artificial intelligence computers to go through that kind of information. And even if they have an AI, what they're going to find out? They're going to find out is if you take 4 together, no one's ever looked at that. They don't know if it's dangerous or not. No one's done the research.
I had a student, 2nd year of teaching, pre-solo, about to solo. When I say about to solo, 15 minutes from soloing.
Okay.
In the pattern, everything's going well. And then all of a sudden, stomps full left rudder, screaming, gurgling, and locks up on the controls. The instructor was able to land the airplane, call fire rescue. This guy thought he was dead. Ends up coming back to life after like 3 minutes of being unconscious with, once again, in slow flight, in the pattern, low and slow, full left rudder, has his hand on the power, brings the power to idle, totally locks up. Instructor says, incredible that I was able to get it on the ground. Fire rescue comes, they speak to this student, and the instructor tell you this is what happened. They try to get information from the student. Very abrasive, didn't want to give him information. Okay, cool. So that incident's over, they fly back, and then the instructor reported it, contact the FSDO, hey, I've got an incapacitated crew member, this is what happened today. And they say, okay, well, he wasn't pilot in command, he wasn't a required crew member, so it kind of went nowhere, but it was reported. And sit down with the student, just ask him, hey man, are you on any medication? And he said, yeah, I'm actually on a medication and I just switched it yesterday.
Oh,
Yeah, and it ended up being, I don't remember the details on it, but he had to stop training, went to his AME and said, hey, I've got this other doctor and I changed these medications. Who knows whatever happened with that, but we never saw him again. And it was properly reported, etc. But yeah, changing medications the day before a flight, combining medications, that's definitely something that I'm sure you'd agree should be monitored prior to getting into a cockpit, especially if there's a dramatic medication change the day before, right? For something that's being treated over X amount of time. Probably the longer it is and the more dramatic the medication is. So that's the only thing I've ever seen, at least in 10 years of flying, where a medication was changed and something that dramatic happened.
you're right. It's a huge risk. But it's not only for the first student. Okay, you've been through instruments and you're far along in your training, and now they switch to medicines. You're going to report it? Well, not unless the doc tells you to, because you're healthy, as far as you know. And so somebody with significant time can run into the same problem, just getting surprised. How about surprise with illicit drugs coming across the border, and you take them and you die, and the ambulance has to give you an inhaler to bail you out?
Narcan.
Narcan. These drugs are so potent, so terribly potent, that the person has no idea until they die. And I have in the internal medicine world, had a lady who was a paramedic. And she came in one day and she works on the southwest side of the city, which is kind of a rugged part of the city. I said, have you used Narcan recently? And she said, I used it twice this morning. I said, yeah?
Twice this morning?
She saw the same person. The pusher had got a hold of some bad stuff. The person took it, died. They got the Narcan, took him to the hospital. By this time, they metabolized it. They're fine. What's the hospital going to do? Nothing. They haven't broken the law that you can prove. They're not at risk that you can prove. So they go back to the same area of the city and they find the pusher and they get some more. They die a second time. Unfortunately for this person, the medics got her that time too and saved her. The problem with Narcan is you can't depend upon someone having it. In the southwestern part of Ohio, there's a sheriff's department. They're prohibited from carrying Narcan. It was eating up the resources, so somebody said, now let him die. Now, that's probably not what they said, but that's what it meant. And it's a huge problem. The kids nowadays, who knows what a kid's taking when they get a gummy picked up at school? Grandchildren. I have grandchildren in that age group. Scares the liver out of me because they don't know what they're doing. They don't even know it's important. They've never seen anybody die. So it's conceptual to them, maybe. Don't know.
Have you encountered a situation where in the process for issuing medical certificates encounter people with surgeries that were no big deal, surgeries that were a big deal? What's the special issuance process with that? Because I know people that have had quadruple bypass heart surgeries and still can get a special issuance. And it's fantastic. It's like they had a heart overhaul, right?
Yep.
And they're still able to pursue their passion and also their career. So it's not this, if someone has a heart surgery or this kind of surgery, they can't get a medical. It's a process, but what kind of surgeries have you seen where here's a special issuance process, this is what happened, and they get the medical? What kind of surgeries?
Let me start off with the most dramatic one. When I was going through AME training, they had a picture of a CAT scan of the brain, and half of it was missing. Backstory. The pilot was a RAF fighter pilot. He had a cancer And they found out it had not metastasized. It was primary brain cancer. So they went in, they took out half of his brain. After a month or two, he could not tell that he had surgery. Nothing was changed. His thinking processes, his reflexes, everything was the same. So RAF needed instructors, so they thought, I wonder if this guy can fly an F-16. The answer was yes. He started out in jets that had another pilot, of course. He had no difficulties. He's now back to instructing in the RAF. Well, he was a while back anyway. Vein graft bypass surgery. The number of vessels are bypassed more has to do with the surgeon's skill than anything else. They get carried away with fixing everything. They only have to fix 70% narrowing, but let's say there's 70% narrowings. You got to go after them? You better. So they're very, very good at bypassing very small arteries. And that's where the American Heart Association committee stuff that I was involved in came from, or what it came up with. If you can reverse the process of medications and you put them through a stress test, various whatever kind, and they don't have evidence of ischemia on that test after surgery, can they fly? Yeah. Do they have to be tested? At least once a year, yes. Now, what if they're on the medications that make the whole process slowly go away? Well, then after about 7 or 8 years, the feds won't be interested anymore because they've missed the deflection point here where bad things are going to happen. Other surgeries, once they're released by the surgeon, the feds say, okay, fine, because there's no reason for the surgeon to release the patient if they're not healthy. That would be stupid, and they don't. Cancer. Again, you can fly with a whole bunch of different cancers. Prostate cancer. If it is not outside the capsule of the prostate, it can be approved by the AME. I can do it. Doesn't have to go to Oak City. It's a case-by-case type thing on some cancers that we don't have a lot of experience with. I can't think of what one of them would be. But in that world, then they might have a case presentation where some specialists from around the universities will come in and they'll vote. But by and large, if they don't have any symptoms after surgery, one way or another, they can go back to flying.
One of the things I want to talk to you about is aging out. What I mean by that is, airline pilots have to retire. It's a congressional thing. 65 years old, you're no longer going to work as a 121 airline pilot. What I'm seeing, the most experienced people that can get on an insurance form for different specialty trainings, jets, turboprops, high-value helicopters, there's a certain point, and I'm seeing it in the high 70s, where the insurance company won't let them be on there because of their age. They still have a first-class medical certificate. When are you seeing that pilots are aging out and can't get a medical certificate? First, second, third, whatever. What age are you seeing that and why?
The age is actually dependent upon how much money they're willing to spend for insurance. I flew in basically a Saratoga for a number of years. I stopped very recently, like 2 years ago, because I couldn't afford to be insured on it. Can I still fly it? No, as well as I could ever fly it. So now I fly a Cessna 152 with a stool package. I'm perfectly happy with that. It goes up and down, and my grandkids don't care if we're not going to Florida. It's just the same thing. So when do you lose your skills? I don't know. The physical skills is depending on how healthy you were and how lucky you were. Back pain, extremity pain, arthritis, that kind of thing enters into the consideration. Mental faculties, I have 3 wonderful children who are now in their 50s, and we have an understanding. They're going to tell me when I can't do something, whether they don't know how to fly airplanes, but that, or drive a car, or when my judgment is obviously not proper. And I'll believe them. When does that happen? These rhetorical questions, I don't know. The problem with the commercial pilot going to 67 is that there's a whole bunch of stuff that happens in the late 60s, heart disease, cancers, and so forth. So are we going to have to increase the testing for older pilots? Well, we do for other things, internal medicine and so forth. But for pilots, probably not. What we don't know is if that's a risk factor or not. At least I don't know. It's not a new problem. So if your mental faculties are good and you are physically intact, what's the next reason? Boredom. At some point, the pilot's flown enough that they really just don't want to see another anywhere. It's just not fun anymore. And so that's one of the big reasons the pilots at my level just quit. They're not having fun. And they'll still go to Oshkosh, maybe. They'll still get a flying magazine, maybe. They might still go to breakfast with other pilots in a Liars Club, maybe. But flying an airplane, they're done. They're cooked. It's just not fun.
When you say the Liars Club, what do you mean?
Well, my Liars Club, the other three are just absolute liars, but I try and tell the truth. So we meet for breakfast every Wednesday morning, and they're quite good. They're all pilots still. But we tend to talk about things other than flying, whereas 20 years ago, the conversation would have been aviation.
You have such a diverse medical background. At one point, you were a coroner, right?
Yes.
And what made you go into that? Because that's, I mean, you know, there's many areas of medicine that are morbid, but you went to one of the areas that is the most morbid. How did that come to play?
One of my partners, I had 4 at that time, was from the community, and he decided to run for office. And since he was a physician, he ran for coroner. Well, we were partners, so that means we became coroners also. So we got the badge and so forth. What a coroner does is, the coroner says, yeah, he's dead. And the real issue is, was it a crime? Well, when you go to the site of the death, the deputies, they tell you whether it's a crime or not. If the guy was cleaning his gun, and I've seen this one, and it was a .45 automatic, and he forgot to get rid of the last chamber round. So he shot himself in the head. Had one lady was kidnapped in the south side of Indianapolis working in a Denny's. The guy took her to a gravel pit and used a shotgun and blew her brain apart. Well, we could figure that one out. Went out to a house, and the fellow was hanging by his neck in a tree. Got that one figured out. That wasn't a murder. And so most of these things are kind of self-explanatory. And the police don't need us to tell them that the person's dead. They kind of know that. They don't need to tell us if it's a crime because they've usually figured that out. And it isn't like Columbo or something. It's usually pretty straightforward. So then we have the paperwork to say that it's an accident or at least wasn't a crime. Had a gentleman one time, this one was me, it was one of my partners. He got called on a fellow that fell into his combine. Actually a baler is what he fell into. And of course he died. And balers are real hard on people. So we were going through the field, or they were. I wasn't there this one. One of the sheriff's deputies said, "Hey, Doc." The guy's name was Mike, the doc. He said, "Yeah, I found his watch." Okay. A couple minutes later, "Hey, Doc." "Yeah." "It's a Timex." Okay. A couple minutes later, "Hey, Doc, it's still ticking." And that goes back to a commercial the Timex used to have. Takes a beating, keeps on ticking. It was situationally kind of humorous at the time, except the gentleman was deceased. But there's graveside humor in a lot of things you do in medicine. That's just kind of one of the examples. It's a way for the medical personnel to kind of dampen the grief. You don't tell people about it because it's not really funny. But dead people aren't.
Do you know who Richard Kuklinski is?
Who?
Richard Kuklinski?
No.
He was a hitman for the Gambino crime pen in like the 70s, 80s. And what he would do is he would plan the actual deceit of law enforcement, where he would kill somebody, then he'd put him in a big freezer for a year, 2 years, 3 years to confuse the time of death. And they ended up calling him the Iceman, Richard Kuklinski. And there was actually a movie about it. It wasn't a very good movie, but excellent documentaries about him. I mean, really fascinating stuff. One of the ways he got caught, his downfall is he dumped one of the bodies on a hot summer day, and it was discovered sooner than what he was hoping. So when a jogger found it, the medical examiner opened up the body on autopsy and said, there's no way this person died 3 days ago because it's a hot summer day, and he found ice in the body. Have you ever encountered any weird things like that in a death investigation?
No. It's pretty straightforward when we get involved. The only good thing about being a coroner is you can arrest the sheriff.
Have you ever arrested the sheriff?
No, he was a friend of mine and I threatened him.
Okay. What's the weirdest? I mean, how many autopsies have you done?
After medical school, none, because you do it in training, and after that, of the 130 specialties and subspecialties, that ain't one of them for an internist. So if you're really interested, you can go in and watch, but you'll get the same thing in the printed report in a day or two. And they'll also have the chemistries and so forth, so you can really determine what the cause of death was, as opposed to the details of, yeah, they're dead.
What's the weirdest case you've seen?
The weirdest case was the one I talked about, the black bear in the garbage pit in the Air Force. That was weird. I have other weird ones, but I probably shouldn't be putting them on tape. It's
Okay. Could you walk us through a typical day in that job?
internal medicine or AME.
No, in the coroner's office.
Oh, nothing's typical. It's just like if you're in law enforcement, what's a normal day look like? There is no such thing. They're all varied. And what you don't want is the ones where there's a huge amount of emotion. I got called out one night, 3 a.m. I had a Porsche. I was blasting down through the country road. I knew no one's going to arrest me because they were all where I was going. And so I got there, and the deceased had been in a convertible, a Pontiac as I remember. He was pretty drunk, that's common. And he managed to run into an abutment. And back in those days, there was no protection for the gas tank, so it exploded. So he had his seatbelt on, and whether he tried to get it off, we don't know. But he was pretty well burned up by the time we got there. The problem, someone had to tell his wife. She was a quarter mile away at their house. She didn't know he'd hit the bridge. That wasn't much fun. I've doing an intensive care meeting, medicine. I have had as many as 3 deaths in one night from intensive care. You have to go out and talk to the families, and that's no fun. The emotion that you see is usually from the person that had the least. They hadn't solved the problems in the relationship, so they felt guilty. So they were the ones who were screaming and crying and so forth. And the ones that had a good relationship with the deceased weren't happy, but they didn't have defined emotion like that. And handling the secondhand emotion of somebody else dying, that's just tough.
How do you approach that? How do you approach working with the families of the deceased?
You just go do it.
Roger that. If you could wish that the public had a better understanding of the coroner's office, what would it be?
the only reason a coroner exists is to ask whether or not it's a crime. So you can't put so much emotion into that. They've already been told usually that the person's deceased. The police will tell them that. So now when you have to face, it's when you're doing clinical medicine, you have to face it. I should mention artificial intelligence. It's going to change everything, but no one knows how. So is that going to be good or bad? Because if the AI is wrong, do they believe the doctor or the AI? We have no idea whatsoever. You're going to end up being an arbiter of the AI, which is kind of silly. You just have to define whether it's probably right or not right. So what are you going to do, run another AI to find out if the first one was right or wrong? Maybe.
With all the physicians, every physician that I've met, I notice after a while, after residency, after a fellowship, after working in a hospital, etc., they start to become desensitized, because it's nice to be around people that you help. It's nice to see people go in, they get better, they get out of the hospital. But part of being a physician is being around sick and dying people at the hospital. Part of being a physician is seeing people take their last breath, seeing people in the worst possible shape, horrible trauma. How do you handle that emotionally? Do you feel you're desensitized?
Not as much as I'd like to be. I have 500,000 people. I don't know how many dead people I've seen or dying, but a lot. I've never seen one die scared. That means something.
Yeah. The couple people that have gone and come back have all told me that there is a calm and a sense of peace. And people that have narrowly escaped or flatlined and came back, right? What do you think that is? Do you think that's every psychedelic chemical going off in someone's brain where they're kind of hallucinating that, manifesting that, or do you think that's something else?
There is a podcast from Lex Friedman. Lex Friedman was born in one of the countries of Russia. He's a PhD. He's extremely good. One of the people that he interviewed a while back was dealing with what comes first, the Big Bang? Well, most people don't think the Big Bang started anything. It just defined expansion. So what preceded the Big Bang? And the guy that was discussing it said, consciousness. In the Bible, the Word was God. Okay, what came first? Consciousness, awareness. And this fellow is also a mathematician, and I was a mathematics major in college, but I couldn't add 2 + 2 nowadays. This guy went into terribly good math. He was also an astrophysicist and basically a PhD philosopher. And he and Lex had an interesting conversation. Again, it lost me. But the concept, is there a consciousness that preceded reality? I think there probably was, but I have no idea what that means. So I've had people, had a lady one day, I was on one of the floors of the hospital. I was in the intensive care unit doing something. Nurse called me up and said, can you come and check this lady? Sure. So I went over and she was in her late 80s. So I walk in and she's looking at the corner where the wall joins the ceiling, and she said, I have to go. So, obvious question, you have to go to the bathroom, da-da-da-da. Couldn't find anything. Normal examination. Went over the unit. 10 minutes later, a nurse said, she's dead. She saw something.
can't not give you chills.
Still does.
Yeah, that's 10 minutes later. I mean, you can go down a rabbit hole of wondering and wondering about that for the rest of your life, which probably is what we all do.
You have to. Is there life after death? I happen to be a Christian. I'm not sure what that means. Is there life after death? I hope so. The consciousness, if that were correct, would be a way to look at that. I think physicians, almost all physicians believe in a deity. I think that's proper. Thank you.
Yeah. Want to take a break?
Yeah.
All right, let's do it. All right, Stanley, so we're back from the break. What's next? What's next for your medical practice? What's next for AMEing? What's next for life?
Grandkids. The last major pivot. Now the people I take care of are mine. My children, my grandkids, friends. Medicine. Medicine isn't what it used to be because hospitals have purchased physicians to maintain their referral area. Started in the early 90s. I was chief of staff at the hospital at the time. And historically what happened was the American Hospital Association decided that hospitals should own things. So in our case, the board of trustees were a bunch of people from the community that were not medical, but they were bright. So the hospital administrator hired a consulting company from Cincinnati, Ohio to come in and give recommendations. Well, they knew what they were supposed to recommend, which was the hospital take over the world, and they did. So then that went to the board of trustees, who really didn't know what was going on, but it sounded sensible to them because as it was presented to the hospital trustees, if you don't do this, they, which would be the larger hospitals in the city, are going to come down and do it anyway. Okay. Well, so they started buying up practices. The group that I'd started had 10 physicians in it at that time, multi-specialty, and we really didn't want to be bought. So we held out for a while. I moved to Indianapolis and went into a teaching position, and then since then I've done a couple things different. But the hospital bought the practices. Well, that means now you have a medical student coming out of school, they got $250,000 worth of debt, and they go to a local bank and say, I need a $100,000 loan to start a practice. Oh no, that won't happen, because they have no collateral. They may have 2 kids, young wife, and they're over 30 years of age. So who's going to pay them money? Hospitals. They have a different tax structure, and they can do that sort of thing. So they do a bait and switch. Say, hey doc, if you come over here and work for us, we'll pay you $1 million and you'll see 2 patients a year. After a short time, couple of weeks, administration comes out and says, hey doc, you know, this isn't going well. We need for you to see 40 patients a day. The actual number is about 30. How do you see 30 internal medicine patients a day? You don't. So they end up seeing people for maybe 8 minutes. And who actually provides the care? Well, might be a physician extender, a nurse practitioner, something, or maybe nobody. So people coming in, let's say a young person wants to go into medicine right now and they ask my opinion. Run. You can make more money somewhere else. you're not going to have a whole bunch of fun in medicine nowadays. Someone else is going to tell you how many people to see, decide your specialty, decide everything about your life. Well, that's exactly anathema to the personality that gets you in that in the same place. To say someone comes in and tells you the same thing. Really? How far is that going to get them? Not very much, because your personality will not accept that. Physicians are the same thing. No, I won't do that. But by the time they get to that point, they can't make it. They can't do anything else. They still have a mortgage on the house and now have 3 kids, and they're working 70 hours a week, despite not seeing very many, helping people very much. And it's disquieting. So people like me, we're just really tickled that we got out alive. I have many very good friends that are still in there. They're not having much fun. The analogy in the world is law enforcement, military, firefighters. You know, you're doing stuff that has to be done. You want to do it right, but how long can you work at that speed? And the answer is you can't. When I was doing 100-hour weeks, I slowed down to 80-hour weeks. It's like I had too much time on my hands. Well, I also had 3 children. I got to use the time just fine. So now with grandkids, that's the future. So relationships, that's the future.
A guy once told me there's 3 main chapters in life. You learn it, you earn it, and then you return it.
That's good.
So I got something for you before we wrap up. When we flew the helicopter yesterday to that party and I saw you light up, when I got that thing a month ago, they gave me the helicopter, a dolly, then 2 big bags. Look inside the bags, there's oil, there's a bunch of maintenance records, all kinds of cool stuff. And then there's a box, and I said, what's in the box? And they open up the box, and it was a model of the aircraft. So I put it together this morning, and I want to give it to you to put in your practice, in your
Perfect.
doctor's office. And it was very special for me to see you light up as we flew around. So we'll definitely go do it again soon.
Good.
Thanks for coming on the show.
Thank you for having me.
Awesome.
This is beautiful.